kind introduction, and thank you to all my colleagues who've made the time to attend the webinar tonight. We seem to be quite a diverse group, and my hope is that by the end of the evening, we will all unite in common purpose for blood health and to reduce the scourge of anemia. So anemia is a global public health challenge, a condition so prevalent that it has been normalized. And I want to start by defining anemia, which is a decreased red cell count or hemoglobin level. And it takes into account the patient's age and gender. So this is the WHO hemoglobin thresholds for normal hemoglobin and for diagnosis of anemia, which can be graded into severities, either mild, moderate, or severe. So adult males and from the age of 15 years onwards, hemoglobin of 13 or higher is considered normal. In non-pregnant women, 15 years or older, the hemoglobin level of 12 or higher is considered normal. In pregnancy, the hemoglobin level varies according to the different trimesters, starting at 11 in the first trimester, going to 10.5 in the second, and usually 10 in the third and postpartum. So for the benefit of non-medical people that might be on the webinar tonight, this is a typical red cell, and they are essentially bags of hemoglobin. And the hemoglobin is a combination of iron and protein. And this is the structure that helps to carry oxygen to all the tissues in the body. And this little red cell will travel hundreds of kilometers in its lifespan of 120 days before being destroyed in the spleen. So whilst WHO has set these thresholds, lately they have prescribed a hemoglobin of at least 13 grams per deciliter for both males and females in the preoperative stage, that is, patients going for surgery. Now, before I go any further, I want to introduce you to Prof. Axel Hoffman. And he's a leading international expert whose work has shaped how hospitals have improved anemia management, reduced transfusions, and improved clinical outcomes. He was at the Hematology Conference in Cape Town last year, and this is what he had to say about anemia. Anemia is a killer, and he's well qualified to make that statement. So essentially, this webinar is about anemia, and I've timed it to usher in World Anemia Awareness Day, which is marked on the 13th of February. And the date is significant as it represents the ideal hemoglobin of 13 grams per deciliter for optimal blood health in adults. So the scope of talk will cover some broad concepts of blood as an organ and blood health, anemia as a major public health priority, and the evolution of patient blood management as a solution to the crisis of anemia. So modern view holds with blood as an organ on the basis that it has structural complexity containing both cellular and non-cellular elements. It has varied and coordinated physiological function that includes hematological, respiratory, immunological, hemostatic, hormone transport, fluid, and pH balance. It also has a close and complex relationship with vascular endothelium. And additionally, blood has regenerative capacity if the correct conditions are met. So hence, we now look at blood transfusion as an organ transplant. I want you to file this idea for now because it will surface later on in the talk. So accepting blood as an organ then naturally progresses to the concept of blood health. Ozawa and team defined blood health as the optimal function of individual elements of blood and their associated interactions with all other organs and organ systems. And one of the key indicators of blood health is the hemoglobin level. So just as we have established strategies for health of other organs like cardiac and renal that include defining goals, preventative measures, diagnostics, therapy, monitoring, and follow-up, the same should apply to blood as an organ. And this form of medical care for blood health is called patient blood management. So in this publication, again by Ozawa et al., they defined blood health and crystallized very clearly the benefits of maintaining blood health being, and in the statement, maintaining and optimizing blood health has shown to have a significant positive effect on general quality of life, productivity, and overall cost of health care. The term patient blood management was initially proposed by Prof. James Isbister in 2005, and he described a patient-specific approach with the aim of improving the patient's clinical outcomes by managing and preserving the patient's own blood, just like any other organ or organ system, and then giving rise to the concept of blood health. So the current formal definition of patient blood management is that of a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. And you will note that in this definition, the word patient appears 5 times. Right? So patient blood management is underpinned by 3 pillars, and that requires a multidisciplinary, multimodal approach. The first pillar describes optimizing the patient's own blood or red cell mass, and this is proactively managing anemia using an etiology-specific approach. Pillar 2 involves minimizing blood loss, thereby preventing anemia and reducing the risk of transfusions. Pillar 3 requires supporting and optimizing the patient's own compensatory mechanisms so that they can safely tolerate a lower hemoglobin and again avoid unnecessary transfusions. So in a sense, what this means is that one needs to take into account individual physiology to guide decision-making and not simply transfusing to fix lab numbers. In clinical practice, the pillars are intertwined, and indeed patient blood management is most efficacious when bundles of intervention are applied. And of interest is that although patient blood management was initially developed for the surgical discipline to be applied from the pre-op to the intra-op to the post-op stages, the evidence is clear that patients across the medical spectrum benefit from this model of care. And certainly, if implemented with consistency and intent, patient blood management can turn the tide of anemia and its commonest cause, iron deficiency. So at this point, I'm going to trace the roots and evolution of patient blood management to better understand the present practice. At the end of the 19th century, surgeons began practicing elements of PBM by examining the blood, curtailing hemorrhage, and increasing tolerance to anemia, as transfusion was not an option. So the three-pillar concept actually surfaced at a medical conference in Australia in 1899. And I have to say that, you know, the Australian medical fraternity has certainly set the pace in the practice and implementation of patient blood management. In 1901, Karl Landsteiner discovers the ABO blood groups, and he subsequently earned himself a Nobel Prize for Medicine in 1930. The year 1907 marks the first successful transfusion using typing and cross-matching processes. And then we see a steady growth in units transfused through both world wars, accelerating in the 1950s owing to advances in cardiac surgery and trauma care. In 1960, the principles of bloodless surgery was developed by Dr. Denton Cooley, principally as an advocacy for patients refusing transfusions on religious grounds. He used a three-step approach that involved optimizing the patient's blood preoperatively, using techniques intraoperatively to reduce blood loss, and allowing patients to tolerate lower levels of hemoglobin while providing supportive care. And using this three-step approach, he went on to perform open heart surgery on hundreds of Jehovah's Witnesses without recourse to transfusion. And he showed that there was reduced morbidity and mortality, and he avoided transfusion complications. So Dr. Cooley felt that his bloodless surgery technique might have been his most important contribution to open heart surgery. And indeed, he's acknowledged as the father of bloodless surgery. So continuing with the march of history, in 1981, we received the first formal reporting of a clinical case of AIDS. In 1984, we see HIV has been identified as the causal agent. And it's 4 years later that the FDA approves an ELISA test for HIV screening of all blood donations. So by the late 20th century, there was a recognition of a number of transfusion-transmitted infections that fueled advances in protocols for donor selection and testing that considerably improved blood safety from an infectious disease perspective. But just as importantly, efforts then started to concentrate on the evidence for putative benefits of transfusion. And the conclusion: allogeneic transfusion is a tissue or an organ transplant with significant adverse effect relating to immune modulation, increased risk of infection, and negative impact on the microcirculation. So the growing evidence serves to shift the focus from blood product use to holistic management of the patient, and the interest in blood conservation is revived. But unfortunately, blood transfusion remains one of the most overused procedures globally in current day, as many consider it first-line therapy for anemia. So in 1990, the Fremantle-Kelia Hospital in Australia implemented a comprehensive blood conservation program. And they used Dr. Cooley's three-step clinical approach and expanded on it. In the preoperative period, they optimized the patient's own blood, identified and treated iron deficiency and anemia, and identified and managed bleeding risk, whether inherited or acquired. Intraoperatively, blood loss was minimized, harnessing several techniques: surgical, anesthetic, pharmacological, and they also minimized phlebotomy losses. Postoperatively, they leveraged tolerance of anemia while providing optimal support and treatment for patients to recover their own hemoglobin. And the outcomes were also quite impressive: 84% reduction in transfusion with improved patient outcomes, and a 0% transfusion rate in primary total knee and hip replacement. So, twinning with developments in blood banking and transfusion medicine, it becomes increasingly evident that there is another significant threat to health that permeates all strata of medical care. WHO refers to anemia as the silent epidemic, and with valid basis, considering the staggering burden of disease globally. So it's about 2.9 billion people, that's almost a third of the world's population, with anemia and or micronutrient deficiency, especially iron. And then another 600 million with acute or chronic blood loss and bleeding disorders that partially overlaps with this cohort. And locally, the figures are just as frightening. So these figures come from the SA Nutritional Health and Examination Survey of 2014, and reports 1 in 5 adults as being anemic. There's a prevalence of 22 to 44% in women of reproductive age, up to 43% in pregnancy, and around 10% in children under 5 years. So immediately, we can see the most vulnerable patients that are susceptible to iron deficiency and anemia. Additionally, the South African Surgical Outcome Study reported in the SAMJ of 2018 showed that almost 48% of patients presenting for elective surgery are anemic. So the scale and impact of anemia is not, it cannot be ignored, right? And to add to that, we have the highest incidence of HIV in the world. 60 to 90% of people living with HIV will develop anemia during the course of their illness. They should never be regarded as normal because anemia has been shown to be an independent risk factor for mortality in this group. And reversal of anemia will improve mortality and morbidity. So, isolated anemia in otherwise healthy individuals, it impacts on health and productivity, right? These patients may manifest with cognitive dysfunction and impaired concentration, fatigue, headaches, emotional instability, depression, and restless leg syndrome. So as you can see, the manifestations can be quite protean, meaning that presentation can be to many varied disciplines. In cardiac patients, coexisting anemia increases morbidity and mortality, especially in chronic heart failure and those having cardiac surgery. Anemia in pregnancy, we commonly know it as one disorder and two patients. In the mother, anemia reduces physical activity, it impairs cognitive performance and immunological function, and increases the risk of morbidity and mortality from peripartum hemorrhage. So anemia in the pregnancy also impacts on the neonate, increasing the risk of low birth weight, infection, neurocognitive alterations, and perinatal mortality. The commonest cause of anemia is iron deficiency, and iron deficiency in pregnancy deserves specific comment. So iron supply is prioritized to the red cells to meet the high oxygen requirements of complex and intense structural brain development in the fetus. However, in the developing baby, there is also an intrinsic need for iron for production of ATP in the mitochondria, by neural tissue, for myelination, monoamine neurotransmission, neuronal growth, and differentiation. So iron deficiency in the developmental stages has pervasive consequences throughout the individual's lifespan, predicting for long-term negative effects on brain health, such as reduced recognition memory, slower processing speed, neurodevelopmental abnormalities, poor social interaction, and increased risk of mental health issues. So in this excellent review by Michael Georgiev, he concludes quite profoundly. Thus, ensuring fetal nutritional and in particular iron health can be seen as an investment in the next generation and society going forward. So there's a concept for you that iron deficiency in pregnancy is actually a generational health crisis. Now, in hospitalized patients, the risks of inadequately managed anemia, blood loss, and coagulopathy include increase in mortality, nosocomial infection, increase in acute kidney injury, stroke, MI, increased hospital and ICU length of stay, and the increased risk of allogeneic blood transfusion, all of which impacts negatively on clinical outcomes and ultimately the cost of health care. In this category of patients, transfusion is seen as a second hit. It's an additional independent predictor of adverse outcome, showing higher mortality, ischemic complications, organ dysfunction, infection, delayed wound healing, and increased length of hospital stay. And in 2022, Prof. Hoffman and his team showed that this risk is related to individual unit transfused, that the link is causal and not associative. So in the early 2000s, the growing evidence for a triad of independent but modifiable risk factors for adverse patient outcomes have been identified. And these are anemia, blood loss, and blood transfusion as default therapy. So, taking that into account, the Director General of the World Health Organization was requested to provide guidance, training, and support to member states on safe and rational use of blood products and patient blood management. And the outcome of that was WHO Assembly Resolution 63.12, which advised that all member states to adopt multimodal and multidisciplinary patient blood management strategies to improve outcome. So, apart from the substantial scientific evidence, there are two more compelling drivers for patient blood management, namely ethics and economics. So I'll start with the ethics. Patient education and empowerment, informed consent, and shared decision-making is central to the practice of PBM. So good medical care should also aspire to acknowledge patient values, goals, and preferences in the setting of what they understand about their disease and the best available treatment options, covering risks, benefits, and uncertainties. So, in short, PBM is a prime example of personalized medicine, where science meets art in a happy medium. Ethics related to the blood donor requires stewardship of voluntary altruistic donation and an obligation to use that gift in a responsible and rational manner. And unfortunately, the current widespread practice of transfusion as default therapy is quite contrary. As medical practitioners, we are ethically bound to acquire knowledge and application skills to improve clinical outcomes while securing patient safety and empowerment. And be mindful that the respect for patient rights also extend to patients that do not object to transfusion, but are also entitled to improved outcomes as shown with the practice of PBM. The third driver for PBM is economics, and take a look at what the world's first statewide PBM program achieved. It was implemented by Western Australia Department of Health, and this study accrued more than 600,000 patients during a 6-year period spanning July 2008 to June 2014. So, apart from improved patient outcomes, a reduction in preoperative anemia, and a reduction in units transfused, the savings related to the cost of blood products and the supporting activities were clearly impressive. And this scenario has been replicated in several areas around the world on smaller scales. In South Africa, we are constantly faced with the challenge of curbing expenditure whilst improving patient outcomes. And this paper on patient blood management, a solution for South Africa, was authored by well-known proponents of PBM on both the local and the international stage. And it details the impact of anemia and the benefits of implementing PBM in South Africa. It's an absolute must-read. And the authors concluded that improving the management of anemia will firstly improve public health, secondly, relieve the pressure on the blood supply, and thirdly, improve the productivity of the nation's workforce. The implementation of PBM will improve South Africa's health status while saving costs. However, despite the existence of 3 very solid drivers for PBM, evidence, ethics, and economics, the uptake and integration into medical practice has actually not achieved the required momentum globally and locally. And hence, the WHO policy brief of 2021 was a clarion call for urgent action, emphasizing the unmet need to preserve and optimize the patient's own blood. And the document states quite emphatically that almost every individual can benefit from PBM during their lifetime. In March of last year, WHO released the implementation guidelines for PBM to facilitate uptake. And this 216-page document is the end result of extensive collaboration amongst international multidisciplinary and multi-professional experts. It benefits from a collective experience of healthcare systems that have well-established PBM programs, as well as those environments that face extreme resource challenges. And hence, the toolkits in the documents, it can actually permit customization and implementation in different environments, allowing for application of the 3 Ps, which is promotion of health, protection of health, and prevention of adverse outcomes in relation to blood transfusion. So the starting point would be, to determine where in the health matrix you are, to interrogate your specific working environment, and take into account, what is the range of pathology that you encounter, what is the clinical expertise that is available, and what is the extent of resources. And, amalgamating all of that will help you to develop PBM protocols that are designed for your specific environment. So, in healthcare systems that have well-embedded PBM programs, it's been clearly shown that for PBM to work efficiently, collaboration is key. That within the health matrix, we have to synchronize efforts to preserve and optimize blood health so that it becomes an intrinsic part of medical care. Now, this network includes clinicians, hospital administration, PBM implementation experts, public health professionals, patient advocacy groups, and clinical support that includes laboratory medicine specialists. So, as a clinical diagnostic laboratory, we have also responded to the call for action. And we started by growing our band of PBM certified doctors, of which there are 4 in the team, and nurses, of which there are 2. And our course of choice is the well-constructed short learning program that's offered by the University of Free State in collaboration with SA National Blood Service. So there's a program for doctors and a program for nurses, which are quite distinct, taking into account the scope of practice, but ultimately aligning towards the big picture. This is one of the best career upskills that you will undertake. And also, in hospitals, invest in your nursing team. So this is the task team behind the course. These are well-known personalities in the local PBM community. And, the task team also, and the short learning program is a beautiful example of what collaboration can achieve. So, using the expertise and the knowledge gained, we then began evaluating how to actively support clinicians in the practice of patient blood management. So one of the first tasks involved review of the diagnostic thresholds and reporting comments for iron profiles, thus harmonizing with international practice. The work in progress involves reviewing processes to curb phlebotomy losses so as to reduce iatrogenic or hospital-acquired anemia. And I think this is an area where we can make significant impact when it is coupled with diagnostic stewardship. We are also positioning ourselves as agents for patient advocacy by raising general level of awareness in society and aspiring to bridge between the medical fraternity and the patients we serve. And to this end, AMPATH has launched the Blood Health Matters campaign on the 3rd of February. And we hope with this campaign that will run over a year to amplify the conversation around blood health. Because knowledge leads to actions, and actions can change clinical outcomes. I'm also very pleased to report that the Blood Health Matters campaign is supported by the team behind World Anemia Awareness. They are an award-winning global public health campaign that is striving to spotlight anemia and iron deficiency. The theme for this year's World Anemia Awareness Day is Raise Your Hands for Blood Health. And they will feature a 24-hour digital program around anemia and prevention thereof. And I would encourage you to register and participate. It's a very valuable website for patients and doctors alike. So, in closing, I hope that you will leave with the conviction that every day should be Anemia Awareness Day. And I hope also that wherever you may find yourself in the health matrix, you will try to make PBM an intrinsic part of care, accepting a shared responsibility that places the patient at the center of decision making. I have 2 take-home messages, and that is to remember that the patient's own blood is a precious resource to be safeguarded and optimized where possible. And the health of the blood contributes to the health of all other organs. I thank you for your attention, and I'm happy to answer questions.
Thank Thank you very much, Dr. Rita. So far, we've got one question. At what HB level is a transfusion warranted?
So it's actually a good question, and there's no fixed answer. It's a level that should be individualized, but I can give some broad guidelines. That we aim for a restricted transfusion policy in a patient that is well compensated, not actively bleeding. A young patient, no underlying cardiac issues, we would allow the patient to go to a level of 7, but patients with cardiac pathology, you have a slightly higher threshold of about 8.5. But these are just guidelines, you have to take those values and put it in the context of the individual patient that you are dealing with. And that's why we say PBM is a prime example of personalized medicine.
Thank you, Dr. Rita. I've got another question for you. Let me just see here. Okay. As a nurse, I've had a patient yesterday with an HB of 4.8. Doctor asked to order 3 units of RBC. What health education can I provide to the patient and the family?
So, there's no substitute for history and examination, and that's where we should always start. And then when you look at anemia, it's an etiology-specific approach. So if the decision to transfuse was taken on the basis that the patient was hemodynamically compromised, then what we advise is transfuse 1 unit at a time and assess for clinical response. And if you have a clinical improvement, then you may allow the patient to regenerate their own blood. Okay, so we take a number of variables into account: the patient age, what's their comorbidities like. So, the decision making needs to take cognizance of what's happening in that particular patient, and then investigate the cause of the anemia. And you would treat and give nutritional advice according to the cause of the anemia. If there's suspected GI pathology from the history and the examination, then patient might need evaluation of the gut with scopes and so on. So it's a very ordered algorithm to follow, and one should guard against just using transfusions as default therapy. But I say that I do not mean that you should withhold a transfusion when it's clearly clinically indicated.
Thank you, Dr. Rita. Some more questions coming in. Let's see here. I'm wondering if Dr. Rita can comment on the impact of anemia on a diabetic patient.
So the diabetic patient, might have target organ damage, whether it's vascular, renal, cardiac, and anemia can exacerbate the pathology in those patients. So, we have a mantra in the PBM community to say that the health of all other organs depends on the health of the blood. So I think in whatever category of patient, in every medical evaluation, I think you have to be alert to the existence of anemia, and it's definitely going to have a negative impact on underlying comorbidities.
Thank you, Dr. Rita. Can you touch on the difference between iron deficiency and anemia?
So, iron deficiency describes a state where there is insufficient iron for various processes in the body, right? And iron deficiency depletion follows a stepwise process. And anemia is a very late stage of iron deficiency. So other tissues start to deplete much earlier because the body will always prioritize iron to, to the red cells. So tissues such as your neural tissue, muscles, they will all lose their iron stores first. So that's why you get manifestations like, headaches, the memory fog, the easy fatigue, restless leg syndrome, and so on, well before you actually become anemic. So when one is evaluating a patient, don't have a false sense of reassurance that the hemoglobin level is normal. That patient could still be iron deficient and will still have the same adverse effects, the impact on health and productivity as a patient who is overtly anemic, but clearly they would have more severe symptoms. But so now we define a concept of non-anemic iron deficiency, where patients have a normal hemoglobin, but they are iron deficient. And still quite symptomatic. And those patients you treat exactly the same, manage exactly the same as those that are overtly anemic, which is replace iron and always determine the cause and treat the underlying cause for the iron deficiency. Thank you.
Thank you, Dr. Rita. Another question here. Let me just see. Is there a role for national PBM guidelines, or should they be facility or intuition dependent? How will the delayed uptake be best addressed?
Okay, so the guidelines were released in March of last year, and we do not have a coordinated effort in South Africa to implement PBM at the moment. We don't have a coordinated plan. And what I've been told is that a few hospitals have taken on the guidelines and they have implemented in their own environment. I think that part of the challenge would be, we have a two-tiered health system. We've got varying resources, clinical expertise, different range of pathologies in each, healthcare facility. So I would think that, we would need to get some kind of training on the guidelines on how to implement, and then each facility has almost got to personalize those guidelines for their environment. And it's going to have to be a multidisciplinary effort for implementation to work. So that's where the guidelines are at the moment in terms of implementation.
Thank you, Dr. Rita. Will Empath be revisiting the collection tube volumes required per test and adjust collection of total blood drawn depending on the test to be performed?
So yes, reducing phlebotomy losses, that is definitely a work in progress. And, as I've said in the presentation, we feel that is where, the clinical diagnostic laboratory can impact quite significantly, because hospital-acquired anemia is a huge problem.
Thank you, doctor. Let me just see here. Will Hemopure be an option for an anemic patient in any way?
Sorry, please, may you repeat the question?
Will Hemopure be an option for an anemia patient in any way?
So Hemopure was initially only registered for veterinary use, and it didn't really take off on a large scale. There's a very it was tried used in a very restricted patient population, and the issue with that is free hemoglobin and the impact on kidneys and so on. But we don't have anything hemoglobin substitutes locally as far as I know, but I do stand to be corrected. If there are any anesthetists on the in the audience, I think they would be better placed to answer if there are any hemoglobin substitutes in use at the moment.
Thank you, Dr. Rita. Let's just see. We have another question for you. Someone is saying it's with regards to the previous low HP. Someone said, I have a similar situation. A woman came in with an HP of 10. The doctor prescribed Quadrifer, and the situation seems as though it has not improved. What do you suggest the next step would be for this patient?
So, assuming that we have a firm diagnosis of iron deficiency anemia, and that the cause has been actively looked for and treated, because replacing iron with ongoing blood losses, patient is not going to make progress and won't show optimal response. So that's the first thing is you can see if the underlying cause has been treated. Then we look for compliance, and we also consider if the initial diagnosis was correct, and then whether the dose and the duration of the iron replacement is adequate, if there are any coexisting nutritional deficiencies as well, depending on the age of the patient.
Thank you, Dr. Rita. How would a pharmacist fit into this multidisciplinary approach?
Sorry, won't you repeat that?
How would a pharmacist fit into this multidisciplinary approach?
So I think, and I hope I'm on the right track, that within your institution, you've got to identify a PBM champion, as it were, somebody that's going to hold the whole effort together. And so then, you would pick out key individuals. You have to have nursing staff as part of your team. And you would then try to develop protocols, develop protocols for trauma, develop protocols for theater, for obstetrics and gynae patients. And protocols are good because, they ensure consistency of care and application of therapy. And remember that, when you're in a hospital, the hospital administration is also a big part of that team. I hope I've answered that question.
Thank you, Dr. Rita. I've got another question here. How real is resistance to oral iron absorption in long-term iron supplementation, and what is the best way around this other than IV supplementation?
So, if you've shown that despite best efforts with oral therapy in terms of you've got the correct diagnosis, using the correct dose for the correct amount of time, patient is fully compliant, and you're not really achieving the desired response, then IV iron therapy is encouraged, because the patient should be offered that, because it represents a very viable option to ameliorate symptoms, to improve health. It's not something I would avoid, IV iron. And remember that the products that we use, that are in use currently, are very safe compared to when we started out with the high molecular weight iron dextran and so on. The products are quite safe. So intravenous iron is a very viable option. And I would not withhold it from a patient.
Thank you, Doctor. How long after iron supplementation how long after iron supplementation implementation can one expect results?
So, there's a subjective feeling of well-being within a few days. And we expect to see a 1 gram hemoglobin rise within 2 weeks. So there's also an increase in immature red cells, what we call reticulocyte count. Increase in reticulocyte count is usually by day 7. And, you expect to see at least a 1 gram per deciliter rise in the hemoglobin by 2 weeks.
Thank you, Dr. Rita. Let me just see if there's any other questions. How successful would nutritional interventions be, and would a dietitian be considered as part of the management?
A dietitian would be a very integral part of the management. And, nutrition, exercise, those are all big components in health and well-being. So, yes, if you have access to a dietitian within your, hospital environment, that dietitian must be a part of your team. Thank you.
Thank you, Doctor. Let me see. I don't know. I think there was another question. Just wanted to see. Okay.
I've noticed a few queries regarding the short learning program from UFS. And I want to say that it is an accredited program. It runs over 14 weeks. And at the end of it, you are issued with a certificate from the University of Free State. It's one of the first short learning programs in sub-Saharan Africa, and it's highly recommended. The doctor intake is usually twice a year, I think around January, February, and then again in July, August. The next intake for the nurses are, the closing date is 1st of April, and the course will start on the 1st of May. So you can Google it, but I also had the email address on the slide, pbm@ufs.ac. So if you could get onto that, would be good. Thank you. I'm sorry for the interruption, Yolandi.
No problem, doctor. I found a question. Would you recommend the use of erythropoietin timeously preoperatively?
Yes, there is a role for erythropoietin. And, you know, there are good pre-op schedules that do include erythropoietin and IV iron. And one needs to also, take that into account when you are developing your PBM protocols. And might I add, if you've got access to a hematologist in your environment, they would be a critical component of your team to assist in the workup of anemia, in workup of bleeding disorders, and so on.
Thank you, doctor. We have another question. At what intervals during iron supplementation should you test the ferritin levels?
So generally, we monitor the response to therapy with the hemoglobin levels, and we don't really have a set time for the oral iron. But if you're getting appropriate response in terms of the hemoglobin level, then I would advise checking at about 3 months and to see where your stores are, providing that you're getting adequate response on the hemoglobin level. So you would stop your iron supplements for minimum of 12 to 24 hours before testing. Generally, patients should fast, but not for more than 12 hours, and test in the morning. When you are doing iron levels, one shouldn't be ill because the inflammatory response and so on can affect the levels and make it difficult to interpret. So that's just a few guidelines on how to test for your iron levels.
Thank you, Dr. Rita. If we missed your questions, we will answer them after the event. Dr. Rita will send you an email with the answers. Thank you very much, Dr. Rita, for the informative presentation. And thank you, everybody, for joining us. Have a wonderful evening. Goodbye.
Thank you.